I wanted to point out two things. One is that fibromyalgia only is very rare. So if you are forced as a medical doctor to give as much as diagnosis as it's needed to build up all the symptoms a patient has. So, and if I do it, then it's very rarely that I only diagnose fibromyalgia, because a lot of patients have other so-called functional somatic syndromes or overlapping pain syndromes like IBS, painful bladder syndromes, and a lot, but not all patients also meet the criteria of mental disorder, mainly depressive disorder and anxiety disorder. So it always depends, and this is one problem patients are confronted with. It depends on the specialty. So here the elephant. So of course the psychiatrist will focus on depression, and the neurologist will perhaps focus on myofascial pain. But this is a problem of the patient, and that it's limited to one perspective. But a lot of patient needs a lot of perspective, and that highlights the need of interdisciplinary management of these patients. So fibromyalgia in itself is a very heterogeneous condition, and this is a recent attempt of Dan Claw and Marianne Fitzcharles and me just to unravel fibromyalgia into some different conditions, and this is very important for the management we will discuss later. There can be fibromyalgia as a unique condition. You can have fibromyalgia associated with significant mental health problems. You can have fibromyalgia associated with other chronic overlapping pain conditions, associated with somatic diseases. For rheumatologists, inflammatory rheumatic diseases are important. For me as in gastroenterology, I see the overlap with IBS or with celiac disease. And of course, you can have combinations of subgroups. So there are many patients who have fibromyalgia, they have irritable bowel syndrome, they have chronic tension headache, they have depression, they have agoraphobia, and perhaps they have osteoarthritis if they grow older. So, second important topic for me is severity of fibromyalgia. So in internal medicine as well in psychiatry, we grade the severity of diseases. There are several severity grades of heart failure, of liver cirrhosis, but also of depression. And we tailor the intensity of our treatments according to the severity of a disease. And my suggestion is that we should do the same in fibromyalgia. The problem is that we have no internationally accepted staging of severity of fibromyalgia. There are 6 questionnaires available based on the self-reports to assess the severity of fibromyalgia. The most simple score, because I really recommend it for you to use it, and you will soon have the Norwegian version available, is of the fibromyalgia symptom scale, which is a much better term than polysymptomatic distress scale. And you have, I showed you the scale. You can have 31 points, and there is one scoring of severity, 12 to 19 points is severe fibromyalgia or fibromyalgia, and above 19, 20, up to 31, this is the highest degree. So I'm very much friend because I had the publication of the Patient Health Questionnaire 15. It's also freely available in every language, I think also in Norwegian. It gives you a count of somatic symptoms. And this is internationally validated scaling of somatic symptom severity, mild, moderate, and severe. And what is also used in research is the scaling of the fibromyalgia impact questionnaire. And this is also validated severity scaling in mild, moderate, and severe fibromyalgia. The problem with the FIQ is that it's easy to complete for the patients, but difficult to analyze for the medical doctor. Therefore, if you want to make a grading of severity based on patient self-reports, I recommend to use the fibromyalgia symptom scale or the Patient Health Questionnaire 15, because they are very easily can be assessed by the physician. Of course, the self-report of the patient of his self-experienced disability must not match to my clinical impression. And therefore, in Germany, we have a staging of severity of fibromyalgia symptom or of other overlapping pain conditions based on the medical history. Just to give an example, I have 2 patients who were previous marathon runners but are now suffering from fibromyalgia. Of course, they cannot run a marathon anymore, but they can pretty good do 10 kilometers of walking. If I ask them, they say, oh, I'm really severely disabled because they come from marathon running. So, but for most of my patients with fibromyalgia, but also for healthy patients, I would be happy if they would go 10 kilometers walking. So for me, if I make a comparison between all people, patient diagnosed with fibromyalgia who can walk 10 kilometers, I would say this is a slight form of fibromyalgia because he's only slightly disabled. But the point where the patient comes from, he said, I'm severely disabled. So this is a very clinical staging of the severity of fibromyalgia. It's based on have the patient other somatic symptoms than chronic widespread pain, let's say gastrointestinal urological symptom, headache or not. Has he additional psychological symptoms, anxiety, depression? Yes. No, a little bit. And a lot of patients have slight anxiety disorder or depression, or is it severe? And the same applies to daily function. Have the patient some no limitations, slight limitations, or severe limitations in daily functioning? And of course, all these points are very highly correlated. The more somatic symptoms a patient has, the more psychological symptoms he has, the more disabled he feels. And that's why all the scales who capture somatic symptom burden are also a very good measure of disability. Just to give you an idea what I mean, these are two patient examples. One is a 70-year-old lady, mother and aunt are diagnosed with fibromyalgia. She has low back pain since the age of 11, and then it started with widespreadness of pain. The intensity of pain is very fluctuating. It's better in the summer, and if she is on the Mediterranean, very popular to go on summer holidays, she is nearly pain-free. And there's also some quite variability of the pain intensity scale. She has no other vegetative symptoms, and she has no other increased hypersensitivity to other stimuli like cold, noise. So she is only slightly limited. She cannot carry heavy loads, and she cannot make jogging but walking. She can do her home work, and she has only rare sick leave days. Also, her biographic history and her psychiatric history is completely empty, and this physical examination shows only the tenderness, which is a clinical science, and no other pathological findings. She has no other somatic diseases, and the basic laboratory tests are normal. And of course, the lady had some CTs, but this disc protrusions without any root contact do not explain her back pain. Again, this was a very easy diagnosis, and this is to me a slight form of fibromyalgia. And this is very important if we talk later on management. So this is another form, severe, based on physician's assessment. 45-year-old father suffering from psoriasis, arthritis. The patient has frequent abdominal pain since childhood. And then she was diagnosed with rheumatoid arthritis. She had a complete rheumatological remission of joint inflammation, clinic and by ultrasounds, by methotrexate. But nevertheless, there was a spread of pain in the entire back as well as both arms and legs, but not only in the joints, but also in the muscles. She has a very high pain intensity with very low fluctuations. And she has a lot of other somatic symptoms, recurrent abdominal pain, and then accompanied the spread of pain with some urological problems without any clearly defined urological and gastroenterology diagnosis. We can call it IBS and chronic bladder syndrome. She had a burning all over the body, increased sensitivity to noise and odor. She did slight housework. The most of the housework was done by her daughters or a maid. And she left all her hobbies, and she was for 2 years unemployed, exempted, and lived for an unemployment benefit. And this is a very other psychiatric history with physical and sexual violence in childhood, suicide of a daughter 8 years ago, a lot of working place conflicts, a history of anxiety disorder. Now the patient has developed a severe agoraphobia. She leaves only the house if she is accompanied by some family members. She is feeling down. She has this without any energy. Again, the physical examination is not very spectacular. It shows no signs of inflammation. Also, the ultrasonography and laboratory tests are normal, but the patient has some very internal diseases, somatic symptom load, arterial hypertension, diabetes, obesity, tobacco abuse. You see, this is more than fibromyalgia. These are these internal diseases. This is a patient on a methotrexate, and this is a patient with anxiety disorder and depression. And this patient needs a completely different treatment than the first one. Okay.
Thank you.
I want to summarize. We have different diagnostic criteria for fibromyalgia. I recommend to use the 2016 criteria and to use the fibromyalgia symptom scale as a help for diagnosis. Remember, chronic widespread pain fatigue is not always fibromyalgia. If you want to diagnose fibromyalgia, it needs a complete medical history and physical examination. And if you have a suspicion of another disease, you need some laboratory test and imaging. And if you're a GP, then you should refer the patient to a specialist. But most cases of fibromyalgia can be diagnosed by a GP. And please do also a screening of psychological symptom burden, and as well as you would refer a patient with a suspected neurological disease to a neurologist, refer the patient with a positive screening, for example, the PHQ-4 to a mental health care specialist. And there are different staging of FMS severity available. The most simple is to use is the fibromyalgia symptom questionnaire to scale the severity, and you can tailor your management according to the severity of the fibromyalgia. Thank you.